Welcome to the Vasculitis Foundation webinar today. I'm Kathy Olewski, the host for the Vasculitis Foundation Educational Webinar Series. I love doing these informative webinars as I'm also a patient living with MPA vasculitis. And today's webinar is a follow-up to our recent webinar with Dr. Ulrich Specks on the topic of pulmonary function and vasculitis. We are excited to have Dr. Lynn Fussner with us today to answer some questions. And before we get started, I'd like to introduce Dr. Fussner. Dr. Lynn Fussner is a pulmonary critical care physician and associate professor of clinical medicine at The Ohio State University Wexner Medical Center. After completing her fellowship training at the Mayo Clinic in Rochester, Minnesota, she returned home to Ohio and established the OSU Multidisciplinary Vasculitis Clinic with colleagues in rheumatology and nephrology. In addition to this clinical focus, along with caring for patients in the medical intensive care unit, she conducts clinical and translational research in vasculitis. And welcome, Dr. Fussner. We're so happy to have you donating your time today to answer these questions for us.
Thanks so much for having me. I'm really excited to be here with you guys today.
Great. And at this point, I'd like to ask if you have any disclosures.
Sure. So I do some consulting with Amgen and have a research collaboration with Takeda.
Okay, great. And we got some questions from the recent live webinar with Dr. Specks that didn't get answered. So we're going to start with those today, if that's okay.
Sounds great.
The first question from a patient was, during my last GPA flare, nodes on my lungs were detected. Why does this happen and what does it mean? Are there long-term effects?
Sure. So this is a very common finding in GPA. And I think one important distinction to make is a nodule versus node. And both can be present depending on the disease situation. So a nodule is a very small spot in the lung. So usually less than 3 centimeters in diameter is the definition of a nodule. And there are lots and lots of reasons that people can have them. But in the setting of GPA, we do worry that it's reflective of active inflammation in the lungs. Usually those are usually responsive to the immunosuppressive therapy that can happen. So your team may recommend some follow-up imaging to reassess those spots to see if they get smaller or go away entirely with the treatment regimen. The other term that sounds very similar that might also be present is node. Usually that's referring to a lymph node. Those are tiny pockets of immune cells that sit, usually from a lung perspective, usually they sit in the middle of the chest or around the edges of the lungs. Those can be enlarged in the setting of active inflammation with disease activity as well. We see that less commonly than nodules, but it can happen. And they can also be followed with imaging to make sure they're decreasing with the treatment.
Okay, thanks for clearing that up with nodes and nodules. That is something that does come up frequently in the questions. And the next question is, what are the effects of immunosuppressants or steroids on the lungs? How can I tell the difference between what symptoms are due to vasculitis or caused by the actual medications?
Sure, that's a great question. So really the biggest lung concern with immunosuppression is infection. So by knocking down your immune system on purpose to try to get the disease under control, we increase the risk of infectious complications. And that's really the major thing we worry about the most from a lung perspective with these medications. For the most part, they don't themselves cause much in terms of symptoms or changes in the lungs. There have been historically some rare reports of certain medications possibly causing side effects in the lungs, but those have been very difficult to separate out from really just manifestations of active disease, be it vasculitis or other forms of autoimmune disease or things that would be on similar medications. And so really those are far, far less common and less likely than infections from a lung perspective. And so that's the main thing we keep an eye out for.
Wow, that was a really good question. Thanks for that clarification. Is there any value to having a pulse ox to measure my oxygen levels at home? What are the pros and cons of using one?
So that's a very, very interesting and very personal question and decision, I think. So to start with, what is a pulse ox measuring? So really it's usually a little clip-on thing you might have on your finger as far as a home version. And so what it's measuring is how much oxygen we're seeing on the hemoglobin or red blood cells that are circulating through your system, because that's how our bodies kind of transfer oxygen from the lungs to the rest of our organs. And so it's going to give us a percentage there. And the way our bodies utilize oxygen and the way oxygen interacts with those red blood cells, our bodies can't really tell much of a difference between something that's, say, in the low 90s versus the high 90s or 100% as far as that saturation number. So knowing that, my general feeling would be if oxygen levels have not been an issue for you historically with your disease, it may not make a ton of sense it may not be worth your time, I guess, your time or mental energy is how I would put it, to really track those long term. And then if it has been an issue for you in the past, it's a very personal decision. You know, some folks love a ton of data and really want to track things, and others, you know, you can very easily get preoccupied with those sorts of data points and not be, you know, living your life and doing the things you want to be doing. And so I think that's very much a matter of personal lifestyle and preferences and where you fit on that spectrum of data. I think for most people it's not necessary, but again, something you can certainly talk over with your team as far as how it could fit into your care, but very much a personal thing.
Okay, I know that I have one, and I only use it if I'm concerned about
Sure.
something, kind of just an indicator.
Yeah,
But
absolutely.
it's good to know that, you know, there's give and take as to what that means. Some people think, you know, oh, if it drops below 96 to be scared, but it sounds like that can be quite variable, and we just need to check with our doctors.
Yes, absolutely. We usually wouldn't do anything differently with a number that's, say, 90 or 91 versus a 99, honestly. You wouldn't qualify for having oxygen at home or that sort of thing. And so it may not ultimately make that much difference, but if it gives you comfort to know that your numbers are in a good range, then there can absolutely be value in that. It's really just a matter of how much mental energy you want to put into that.
Yes. And one patient asked, can I strengthen my lungs through therapy so that I won't have to use auxiliary oxygen at home?
Also a very interesting question and kind of related to the prior one. So oxygen levels in the setting of vasculitis, there's a relatively short list of features that would typically be expected to cause, maybe cause kind of long-term oxygen needs. So we're talking more in the range of some of the things that leave really substantial scarring in the lungs, pulmonary hypertension with certain forms of vasculitis, meaning high blood pressure through the blood vessels in the lungs specifically, rather than the blood pressure that we're measuring, on your arm in the clinic, or some heart issues. Sometimes those can drive longer term oxygen needs, but otherwise many of the lung manifestations of vasculitis, with treatment and time, can recover reasonably well, such that we don't often see people that need long-term oxygen. So I'd start with that, I guess, that time and treatment response are really the biggest determinants of whether you might need supplemental oxygen long-term. That said, to get to the specific question of, through therapy or exercises, are there things that I can do to strengthen my lungs and improve the oxygen needs? Usually things like pulmonary rehab, so dedicated therapy, physical exercise in a supervised setting for people with lung issues. Usually that can have a lot of really beneficial effects, but it's usually focused more on kind of exercise tolerance, confidence, frankly, quality of life, just general strength and stamina. It doesn't really directly reverse the lung issues themselves. you're really kind of strengthening the muscles around the lungs and just your overall kind of physical well-being. So that can have a ton of beneficial effects, but we don't necessarily expect it to improve the lung tissue itself to the point of, coming off oxygen if for whatever reason you are needing it long term. And actually, in folks that do need oxygen, it can be very beneficial to continue the oxygen and utilize it consistently in a therapy program like that, because it can increase your exercise tolerance to the point that you can make better gains in your strength and stamina over time.
That's really interesting. It does sound like that really is, the therapy is important anyway for quality of life. And the question about the auxiliary oxygen or supplemental oxygen at home is questionable as to whether it'll change that. But thanks for clarifying that. Also similar, can you talk about asthma with vasculitis? Is it possible to develop asthma due to the vasculitis? And then the follow-up question is, can this condition be managed? And if so, how do you do that?
Sure. So asthma is a frequent part of EGPA in particular. We think it's truly a manifestation of the disease. So within vasculitis, that's the most common setting that we see true asthma. And really the definition of asthma is kind of what we call reversible airflow obstruction. So meaning when you do the spirometry or pulmonary function testing that your team might recommend, where you're kind of blowing into a tube, maybe sitting in a box, the idea is that your airflow is decreased, or you can't move air very quickly because your airways are narrowed. But then when we give you a medication, usually through an inhaler, to try to open the airways, we can see an improvement in that flow. That's kind of the definition of asthma to start with. And so when we think about other types of vasculitis, there are lots of ways that the airways can become narrowed that might show this type of obstruction or reduced flow on the breathing tests. But it's not reversible in the same sense that asthma is. So things like airway stenoses or maybe tracheal bronchomalacia that you might see in some forms of vasculitis or relapsing polychondritis. Those are things that we don't necessarily expect to respond as well to inhaler type therapies, at least as far as the immediate kind of opening and improvements in flow. But asthma itself, if you truly have evidence of that, where you do get that response immediately to inhalers, the inhalers can make a really big difference in kind of day-to-day symptoms and quality of life. With the other types of airway narrowing, they're not technically asthma, but sometimes every once in a while there can be a role for inhalers for the purpose of helping mobilize mucus and get stuff out of your airways, keep them nice and clear. Sometimes we'll use them for the anti-inflammatory effect, thinking that kind of having the medication through the inhaler just sitting right on the airway with some of those stenoses can potentially have some benefit. But asthma itself, is a pretty well-defined lung manifestation or diagnosis that has a lot of treatment options. And so inhalers are certainly the mainstay, and that can be those medications that open the airways. It can be inhaled forms of steroids. And then the other really key piece is managing the kind of things around you or other issues that you may have that can worsen your asthma. So when your airways are irritable like this, where they tighten and then they can open and tighten again, things like postnasal drip and really active sinus stuff can be a big issue, really just kind of adding inflammation to the airways that way. Gastroesophageal reflux or heartburn can be a major trigger for folks as well, when you have really, kind of caustic fluid coming up and getting into your throat and airways that way. Allergies are a major issue for folks. So all of those things are also very important to stay on top of when you have asthma, and frankly, any other respiratory symptoms, I would say. But those are very important for asthma, especially. And then sometimes we get into more advanced therapies if the asthma itself is really problematic, and we start to get into what we call biologic medications that are more similar to some of the things you might see in vasculitis otherwise.
Wow, I hadn't thought of all those different things affecting asthma. That's interesting. I was just thinking, I was wondering about the impact of treatment and management of patients who have pulmonary issues when they get COVID. Has COVID had an impact on the pulmonary system? Like, has it complicated it in any way with your vasculitis patients?
Absolutely. It could be a really challenging issue, certainly. So a big issue up front is just the question of the immune suppression and how much that could be playing a role. As you guys know, being on the immune suppression in the first place can increase the risk of both getting infection, but then also the severity of infection when it does happen, since your defenses are down. So that could be a real challenge. And many patients, appropriately wanted to have detailed conversations about, how do we balance the risks of COVID with continuing the immune suppression for vasculitis, and that's, again, a very personal decision as far as what to prioritize there, especially early during the pandemic. As far as lung manifestations and stuff, certainly we see, like many viruses, it can kind of trigger disease flare and manifestations. Sometimes the manifestations can just be very similar, and so it's hard to tell upfront if the symptoms someone is having are due to an infection like COVID or due to the vasculitis coming back. So that can certainly be a challenge. And then just with the infection, COVID specifically being, so much more impactful on the lungs than many of the other viruses that we, had seen historically, it can itself cause some damage in the lungs, sometimes leaving some scarring or other issues that can cause some long-term challenges. In addition to kind of the long COVID effects that can affect, many parts of the body and kind of people's day-to-day function. So definitely a real challenge and a very personal discussion with your care team as far as balancing all the medication and stuff.
So many things that vasculitis patients worry about. So that was great to have your input on that question. And one last question is, if a patient has lung issues with EGPA, how important is it to also be watching the cardio system? Is it true pulmonary and cardio systems are interconnected?
Absolutely. So I'd say very important. Absolutely, the heart and the lungs are very closely connected, and any sort of impairments in one, will cause the other to have to do more work. And so really trying to keep things in balance is very important there. And yes, EGPA is one of the forms of vasculitis that more commonly affects the heart. It's still not common, I would say, but more common in EGPA than some other forms of vasculitis. And so always needs to be on the radar when new symptoms evolve, and potentially, depending on the patient situation, some periodic screening and that sort of thing.
Okay, well, that's just a good extra thing that we need to be aware of and we need to just keep an eye on. And I also want to ask you, as a patient, are there any questions that I, as the patient, should ask my doctor about this topic? Something that I should be thinking about before I come in my appointment, maybe.
Sure. No, I think there are lots of different directions that could go, of course. But I think some of the stuff that seems to really weigh on people's minds is this concept of, like, when is something considered permanent damage? Something that might not be reversible versus something that we would expect to get better. And in general, the good news is that most pulmonary manifestations of vasculitis respond reasonably well to immunosuppression. There are some types that can be very challenging, though. So I would say airway stenoses can be particularly challenging to manage. So that's like some of the narrowing of airways, often in this small area just below the vocal cords called the subglottic region is a common area, but it can happen anywhere. Those can be particularly challenging to manage and don't always respond terribly well to the immunosuppression alone. So we need to bring in other care team members for some procedures to open things up. So that can itself drive some I don't know if permanent damage is the right word, but stuff that sticks around longer and is harder to melt away, if you will, the way that some of the other things can improve. Otherwise, it's really when we're talking about scar, and that can be in the airways or in the lung tissue itself. Those are the big things that we worry might stick around long term and kind of not be able to be undone, if you will. And so interstitial lung disease is something that we're gaining more and more understanding of in vasculitis, and that really is scarring of that lung tissue, causing the lungs to be less flexible, sometimes smaller, causing the oxygen handling to be impaired. So those are the types of things that when we're talking about kind of long-term or permanent damage that we'd be thinking about. But many of the other pulmonary manifestations of vasculitis, thankfully, can be more responsive. So I think kind of differentiating what we expect to go away versus not is a very important conversation up front.
Well, that's important for us to know as patients so that we get the best information when we're in with our doctors. So thank you so much. And I just want to say thank you for sharing your time with us today. Is there anything else that you want to add before we finish up today?
I was trying to think through some other things that, that come up in discussion that might be relevant or people might have interest in. I think sometimes the question of whether it's necessary to continue inhaled medications when you're on some of these heavy duty systemic medications is a question that comes up, particularly if you're feeling good on the systemic medications. When can you get rid of the inhaled medications? And definitely that needs to be a discussion with your specific care team. But I do think a lot of times there can still be a role for the inhaled therapies. I kind of view them as sort of acting locally, meaning you're inhaling the medication. So sometimes an inhaled steroid, and it'll have an effect. It's almost topical. It's almost like a lotion on your skin. It's going to coat that surface and hopefully have some benefit in that way. That can potentially have a role in facilitating some downgrading of the other heavy duty medications. That's something that we're hoping and actively working on getting more evidence to kind of support and help answer those questions, because they do come up a lot and we just don't have a ton of data to go on right now. But in my mind, at least right now, from what we know, it seems like there can still be a role for some of those medications to try to keep things under control locally while you're trying to back off at the right time on some of the other more intensive systemic medications. And then along those lines, I'm a big proponent of what we call pneumocystis prophylaxis. So Bactrim is kind of a long-standing old antibiotic. That's the brand name. The generic name is trimethoprim sulfamethoxazole. So kind of a mouthful. But depending on the type of vasculitis you're on, or you have, and the type of medication you're on, there can often be a role to have that in place. And it has a few functions. It is one to try to prevent some of the what we call opportunistic infections, or kind of unusual infections that can kind of take advantage of your system when the immune defenses are way down. So it tries to keep those infections out of the way. And then there are some data that suggest It could also have some anti-inflammatory effect, and kind of impact some of the bacteria that many people just have naturally in their systems, to try to, decrease both infections and disease activity. And so it's definitely not going to take the place of the heavy duty medications, but in some patients it can have a role, and it seems to have a bigger role in the ANCA-associated vasculitis patients than some of the other forms of vasculitis. But important to talk with your care team about that as well, and certainly as a pulmonologist, because those infections most commonly cause a lot of trouble in the lungs. I'm probably a little biased, but I think that's an important one to talk over with the team as well. Kind of measures that you should be taking to try to, mitigate as much as you can the side effects or risks of some of the medications.
Well, that's great to hear that you're saying discuss that with your care team, because we try through these webinars to empower patients to feel comfortable asking about things like this. And often as a patient, we're not sure that we should bring up things like this, but that's great to hear you say that you would welcome that. So
Absolutely.
Good for the patients to know that, so that we can remember to ask these questions. Well, we appreciate your time today. We get so many questions in the live webinars. This is really beneficial to the patients who ask questions and their questions didn't get answered in the live webinar. So thank you so much. This will be up on the Vasculitis Foundation website shortly as a follow-up to the actual live webinar that we had. And we really appreciate you giving us the time with the answers that we needed. So thank you today.
Oh, absolutely. Thank you so much for having me. I really appreciate the opportunity to talk with you guys, and always happy to field more questions if they come up. So.